and welcome to the York Festival of Ideas. My name's Laura Jefferson. I'm a researcher at the University of York. I work in gender and health research, and I'll be chairing the session today. It's my great pleasure to welcome you in person, and thank you for coming along despite how sunny it is outside. I've got a nice bottle of rosé waiting for me when I get home. I hope you're all similar. And it's my pleasure to introduce Sarah, who'll be talking to you about her book on rebel bodies. So the event today is created in collaboration with the University of York Athena Swan steering group. The Athena Swan Charter is a framework used globally to support and transform gender equality in higher education and research. So over to Sarah now. Sarah is an award-winning freelance health journalist and founder of the Hysterical Women blog, specialising in health, gender and feminism. She writes extensively on these topics for the iNewspaper, Refinery 29, The Telegraph, The Guardian, Grazia, the BMJ and many others. She was a finalist for the 2021 Medical Journalist Association Awards, and today she'll be discussing the topic of her book, which will reveal the systemic and deep-rooted sexism in medicine, and also explain what we can do to try and bridge the gender health gap. Thank you, Sarah.
Thank you, Laura. Hi, everyone. Welcome to the Gender Health Gap Revolution. As Laura says, thank you so much for coming inside on such a beautiful day when you could all have been in a beer garden instead. And thank you to York Festival of Ideas for having me. So yes, one of the first questions that people often ask me is what the title of my book, Rebel Bodies, means. And for me, there are two parts to that answer. So the first is that rebel bodies are the patients who don't fit the white, cisgender, able-bodied, middle-class male mould that medicine has always taken as its default. So we know, and even the Tory government has acknowledged that our healthcare system since the dawn of modern medicine has been designed by and for men, and specifically by white privileged men. So hysteria, the idea that as women we're at the mercy of our hormones and our wombs, it goes back all the way to ancient civilizations, ancient Greece, ancient Egypt. And what we have is a system in which the male body is seen as the norm, and the female body is seen as unruly, disruptive, inherently broken, and unmanageable. So I'm not a historian, but what I do know is that hysteria is a 6,000-year-old hangover that medicine is still struggling to shake off. And it continues to cast a long shadow over clinical practice today, despite not having been an official diagnosis since 1980. As I mentioned, this male as default approach to medicine doesn't apply to all men equally, so the issues that we're looking at here are intersectional. They're influenced not just by medical misogyny and sexism, but also racism, colonialism, classism, homophobia and transphobia, fat phobia, ageism, ableism, and all manner of other factors and biases that overlap with each other. So although gender is the focus in my book, and it's the lens through which I explore all of these other issues, the book is also more broadly about health inequalities and how to navigate a healthcare system that is stacked against you. In essence, rebel bodies are the bodies that are too other for medicine to know what to do with. So that's the depressing part of the answer. You'll be pleased to know the second part is more optimistic. Because for me, rebel bodies is also about the rebels, the advocates, patient advocates, campaigners who are speaking out, fighting back against the biases, the injustices, the mistreatment that they've experienced or witnessed in the healthcare system. You know, it's the Davina McCalls and everybody less well known than Davina McCall who has been campaigning on these issues for years. And I wanted Rebel Bodies not just to be a catalogue of horror stories and a cry of despair. There are a fair few horror stories in there, but I also wanted it to be a real celebration of advocacy, of activism by patients and also by healthcare professionals. I know that I personally have been so inspired by the campaigns and the awareness raising that I've seen over the last 5 or so years, writing about these issues as part of my career as a journalist. And I genuinely believe that these have been pivotal in shifting the conversation in the right direction and actually putting the gender health gap on the political agenda. I also wanted to show that there are lots of different ways to join in this revolution. So I think, often when we think about activism, we have this very kind of one-dimensional idea of what that means. It's chaining yourself to railings or gluing yourself to the pavement or, marching outside Parliament with placards. But actually, there are so many different ways that people can get involved, can advocate for better care. So whether it's speaking up and advocating for yourself, sharing your story with one person or 1 million people, whether it's starting a petition or a campaign, setting up a support group, sharing information on social media, changing your entire career path. I've interviewed people who gave up their existing career path to retrain as a healthcare professional or a researcher so that they could become part of the solution. And that's where the subtitle fits in. So Rebel Bodies is not just a guide to the gender health gap. It's a guide to the patient-led revolution that is building up around it. And it's also a manifesto for where we go from here. So there are roughly 140 people's voices, experiences, and expertise in the book, most of them women. And that includes a mixture of patients, parents, campaigners, researchers, and healthcare professionals. One of the things I always say is that I am the least interesting and the least important person in this book. There are so many amazing and inspiring people who shared their stories with me. So on that note, I wanted to start with an extract from the book. Chapter 1 is called The Personal is Political, and it explores how even the most personal of issues, in this case health, are also political, and vice versa. And this extract, I think, sums up why that feels so important to me and was really why I wanted to start the book in that place. So the title of a 1970 Carol Hanisch essay, The Personal is Political, highlights the intersection between personal experience and broader socio-political contexts. It is, in the words of Black feminist scholar Kimberly Williams Crenshaw, the process of recognizing as social and systemic what was formerly perceived as isolated and individual. Today, of course, much of what was once dismissed as merely the private, personal concerns of a few women has infiltrated the political and legal sphere. We have gender pay gap legislation, for example, maternity rights, and the legal recognition, as recently as 1991, that non-consensual sex within marriage is rape. At the time of writing, 35% of British MPs are women, and on paper at least, we've never been better off. But despite those gains, so much of what was pissing off feminists in the 1960s is still pissing us off today. The personal is still very much political, and what could be more personal than health? Our mental and physical health impacts on every single aspect of our lives, cutting across work, family, relationships, culture, and political engagement. Not only does our health impact on our ability to participate equally in society, but the decisions of political leaders, whether that's funding for research or cuts to public services, also impacts on our everyday health and well-being. The most obvious example is abortion, which remains the single most politicized healthcare procedure on the planet. With politicians apparently incapable of keeping their noses out of our uteruses, abortion is understandably the most prominent health issue for mainstream feminism, and has been for quite some time. But feminist health activism doesn't begin and end with reproductive rights, although for many years I mistakenly believed it did. As easy as it is to dismiss health as a personal, private matter, the politics of women's health have wide-reaching effects across the whole of society, impacting on patients' families, relationships, and employers. From a purely financial perspective, endometriosis alone is estimated to cost the UK economy £8.2 billion a year, while 14 million working days per year are lost to the menopause. Yet these health issues, and many more, remain marginalised, under-researched and dismissed as normal or unimportant by the medical profession. That attitude doesn't just hurt affected individuals and their families, the literal cost to society is huge. The more time I've spent researching and writing about women's health, the more I've realised that gender bias cuts across the whole healthcare spectrum. Sexism and all the other forms of discrimination with which it intersects affects women's health and the health of trans men, intersex and non-binary people, from our heads to our toes, from birth to death, all over the world. And these health inequalities can be fatal. Women are up to 3 times more likely than men to die from a heart attack, and black women are up to 4 times more likely than white women to die in childbirth. So I didn't want to skirt around the fact that health inequalities are a political problem, and they're exacerbated by political choices. They should also influence our political choices, and I wanted rebel bodies to take a nuanced, comprehensive look at the challenges facing our NHS on both sides of the patient healthcare professional divide. So a lot of my work is critical of the words and actions of individual doctors, but I'm also very clear that the issues we're dealing with are structural and they're systemic. So while every healthcare professional has some personal responsibility for their own practice, it's also vital that we explore these issues in the context of a health service under enormous pressure. We know that even before the COVID-19 pandemic, the NHS had experienced a decade of austerity measures and under-resourcing, putting it under growing financial pressure. A report by the King's Fund in 2017 said the slowdown in funding growth was increasing pressure on staff and storing up problems for the future. Problems which have, of course, been made all too apparent by the outbreak of COVID. Another report published by the British Medical Association in July 2020 said the drastic extent to which the NHS had to shut down routine care during the pandemic was avoidable. It was a consequence of over a decade of underinvestment and cuts to services. So that's kind of the modern context, but how do we begin to understand where these issues come from? As I mentioned, we know that in many ways, these very deeply rooted issues are a consequence of our patriarchal society and of historical attitudes towards women's bodies. And the way that that manifests in practice is as complex as you might imagine. So in her book, Doing Harm, the American journalist Maya Dusenbury talks about 2 key issues, which I think are a really helpful way of understanding this. So she talks about a knowledge gap and she talks about a trust gap. The knowledge gap, obviously, as it suggests, refers to gaps in medical knowledge when it comes to women's bodies and conditions that primarily affect women. So that's gaps in research, but it's also the way that that trickles down into gaps in medical training, medical education, as well as the gaps in the general public's education and awareness and health literacy. The trust gap is the more cultural stuff, which takes us back to that idea of hysteria. So a common example that I hear about a lot is women being dismissed, being disbelieved, being told it's all in their heads, you're overreacting. It's medical gaslighting, it's medical misogyny, and all those other biases that I mentioned earlier. And it was this kind of stuff that first got me looking into the gender health gap, as Laura mentioned. As a journalist and as a feminist, I was frustrated by how often I heard about these experiences from the women I was interviewing, and actually by the impact that it was having on them. So I kept hearing things like, I thought it was just me, I thought I was going mad, I wondered if actually it was all in my head after all. And that prompted me to start my blog, Hysterical Women, which is a collection of women's stories and experiences. Essentially, the idea initially was just to prove a point that these women who all thought that they were alone were not alone, and that their experiences were not isolated incidents, but a much bigger systemic failing. And that ultimately, with a bit of help from the pandemic, evolved into the idea for rebel bodies. As I mentioned, I think the knowledge gap and the trust gap are really useful ways to think about how all of these issues have emerged and evolved. they very much kind of universal ideas that apply globally, whether you're looking at the healthcare system in the US, the UK, or other parts of the world. But Rebel Bodies is written specifically from a UK and NHS perspective. So in that context, I explore a third gap, essentially, which is around capacity. You know, and the book does get unashamedly political about that, about the challenges facing the NHS and its staff, and what needs to be done to fix it. Quick spoiler alert, it's more money, not more clapping. We know that women are the biggest users of health and social care, not only for ourselves when we're ill, but also actually when it just comes to managing all of the womb admin, you know, the contraception, the cervical screenings, the pregnancy, the menopause, but also, you know, in our roles as mothers and as carers. So inevitably we are hit the hardest by cuts to funding and services and by overstretched and under-resourced workforces. There's also evidence that burnout, which for obvious reason has risen massively in the NHS in the last few years, has an impact on healthcare professionals' capacity for empathy. And understaffing and under-resourcing have huge implications for patient safety. You know, we've already seen the very real dangers of the NHS crisis in the last few years. You know, thinking about the various maternity scandals that have come out, but also, you know, some of the stories that are coming out of A&E departments over the last winter. So throughout the rest of the book, I explore how each of these three factors affect women and people who are assigned female at birth across the whole of that healthcare spectrum. And I do that using a sort of broadly life stage approach. So I look at periods, I look at sexual and reproductive health, perinatal health, motherhood, menopause, and later life. But I also, along the way, take in acute physical pain, chronic illness and disability, mental health, and cancer. I think from our very first periods, our pain and suffering are so normalised and have been for such a long time. You know, we almost kind of expect periods to be horrific. We have this idea of the curse of Eve, and that being born with a womb is just, you know, pain and suffering is inevitable, and we just have to get used to it. And yet somehow at the same time, that pain and suffering is also minimised and dismissed as if it's not that bad, actually, and we're all just overreacting and making a fuss. I also explore in the book the conflation of many of these issues with women's sexual and reproductive lives. So one of the ones that I hear about a lot is women with PCOS or endometriosis being told, oh, there's no point treating it really unless it's affecting your fertility. You know, there's also a couple of really horrifying examples I talk about where gynecologists are just recommending hysterectomies as like first-line treatments for things like fibroids, as if it's not major surgery. So I also look at how racism has led to black women being underdiagnosed with endometriosis, and how cultural stigmas make it particularly challenging for women of colour to both realise that there's a problem in the first place and then access medical support. One of the things I was really struck by while writing the book was just how many different characteristics are used to try and justify withholding treatment from patients, and particularly patients who are in pain. You know, so you see women being dismissed as hysterical or told, you're just having a panic attack, go home. Black women are denied pain relief based on the false and racist belief that black people have thicker skin or that they feel less pain, or else they're judged as drug seekers. Fat phobia results in patients in bigger bodies being told that their weight is the cause of any and all symptoms they present with, and that weight loss is the only solution without any kind of test or investigation to check if that's actually true. And trans patients encounter a phenomenon known as trans broken arm syndrome, where their trans status or any gender-affirming treatment they've undergone is blamed for something much more ordinary and everyday, like a broken arm. Or equally, you know, you hear of doctors refusing to treat them simply because they say they don't know how to deal with trans patients. They're scared of getting it wrong. Disabled women too face a whole host of challenges, from physical access and reasonable adjustments not being put in place, to biased assumptions like sexual health services, assuming that you must be asexual because you use a wheelchair. I'm also particularly interested in the number of complex, poorly understood chronic illnesses that disproportionately affect women. So I'm thinking of, the various forms of arthritis, things like ME/CFS, fibromyalgia, and lots more. And many of these have long been contested illnesses, with some doctors still disputing their existence altogether. They're classic examples of conditions where women are told that their symptoms are all in their heads, because GPs aren't able to join the dots. We don't have enough research, understanding, or diagnostic testing to make them easily diagnosable. And with many of them, even if you can get a diagnosis, there may not actually be any particularly effective treatment options to help you once you've been diagnosed. So there are lots of other examples of how this manifests in practice. We see women with mental health issues being dismissed as attention-seeking or drama queens. We see gynecology and sexual health services that still don't really consider female sexual pleasure to be a medical issue or a medical concern, and who very much still view women either as vessels for male sexual pleasure or for reproduction. There's the infantilization of mothers and birthing parents who are too often denied bodily autonomy at such a vulnerable time. There's the ageism that comes in when older women are dismissed as past it. There are even, despite the ubiquity of breast cancer awareness campaigns, inequalities when it comes to cancer research, diagnosis, and treatment. There's also, I think, a misconception in women's health spaces that menopause is where the conversation ends. But actually, most of us will live for 30-odd years post-menopause. That's not where life ends. And we don't ever really talk about the fact that women with dementia outnumber men 2 to 1, or the fact that cardiovascular disease kills more women than breast cancer. Declining estrogen levels impact on both of these, as well as increasing the risk of osteoporosis, which becomes an increasing issue as women age and their fall risk increases. So, for example, women are more likely than men to break their hip. Similarly, issues like unaddressed postnatal incontinence can become much more problematic in later life, and actually it's one of the leading reasons for older women being moved into care homes. We also, on that note, of course, need to talk about the fact that many women who are going through the menopause may simultaneously be caring for elderly parents and young children or grandchildren, and it is overwhelmingly women who pick up these caring responsibilities still. So, that's all quite depressing and bleak. Onto a more positive note, as I mentioned, I wanted Rebel Bodies to feel hopeful as well, and to be a celebration of that kind of patient power and advocacy that we've seen, as well as highlighting some of the amazing healthcare professionals who are also doing fantastic work from within the system. I've been writing about these issues to a greater or lesser extent for the last 5 to 10 years. And a decade ago, virtually no one was talking about these things. You certainly didn't have household names like Davina McCall doing mainstream Channel 4 documentaries about them. And now it's such a hot topic that the government had to publish its first ever women's health strategy last summer. So I think for all the negatives, for all the things that still need to change, it's important to remember that we have come a long way in a relatively short period of time from a cultural perspective, at least. And there are lots of fantastic grassroots campaigns and organisations that I highlight throughout the book. So the groups like Sisters, who support South Asian women, trans men, and non-binary people with reproductive health issues. There's 5 times more who campaign for improvements to the perinatal health care that Black women receive. There is Sling the Mesh, who got vaginal mesh suspended as a treatment for incontinence on the NHS. There's the Make Menopause Matter campaign, which really laid the groundwork, I think, for some of the more high-profile campaigners, including Davina, who have since entered that conversation. And these and many, many more, I think, have been really central to amplifying women's stories and putting these issues on the political agenda. The other significant change in the last decade, I think, is that women's health has become big business. And in our capitalist society, I always kind of think that's the marker of success in lots of ways, when a fringe issue goes mainstream. Very similar to the way that feminist slogan T-shirts and so-called femvertising suddenly became this huge kind of emerging market in the 2010s. And it's a real double-edged sword because on the one hand, as I say, it shows how far we've come culturally, but and it leads to some fantastic innovations, people finding solutions to fill gaps in the market. But it also leads to exploitation and to less positive impacts. I think femtech and the women's health sector more broadly really has seen a lot of great female-led innovation. So we've seen things like period pants, alternative pain relief options, period tracking, menopause apps, all of these kinds of things, many of which have come from women's own personal experiences of feeling frustrated that there weren't products out there that met their needs. But there's also a lot of junk out there, which ranges, I think, from stuff that is harmless, that is only going to hurt your bank balance, but that is ineffective, that's not evidence-based, but very, very expensive, through to actually stuff where there are potential risks involved and where, we've seen organisations like the Royal College of Obs and Gynae having to put out statements about certain commercial products that are dangerous. The wellness industry is a multi-billion-dollar industry for a reason, and I don't think it's a coincidence that it primarily targets women. And one of my biggest worries that I talk about in the book is that the gender health gap kind of directly fuels some of this market. If women are desperate, they're struggling with symptoms for months or years without getting the help that they need from their doctors, they will look elsewhere. They will look to, perhaps influencers who make them feel validated. And you can well imagine how they might be desperate enough for some kind of relief, some kind of solution, that they will pay whatever price for whatever cure or solution is being promised. So as patients, I guess, the big question that I get asked a lot is how do we navigate all of these issues? How do we get the healthcare that we need? And I'm afraid I don't have easy answers. A lot of the solutions are not cheap, and none of this is going to change overnight. We need a massive catch-up in research. We need a well-resourced healthcare system. We need better medical education and better public awareness. And all of those things need substantial funding and political will, which I'm not convinced we really have yet. I end each chapter with a toolkit containing tips and resources for navigating the healthcare system, but always with the caveat that I don't think the onus should be on patients to fix all of this. And if you are treated badly, it's never your fault for not trying hard enough. Not everyone has the privilege of being able to advocate for themselves at all. And for those who do, there is still no guarantee that speaking up and challenging your doctor's opinion will get you anywhere, because the balance of power is not in our favour. That said, I do think that patient power has got us to where we are today, and that we can and we must keep up that momentum. So generally speaking, in terms of things that people can do, we can keep talking about this, we can keep lobbying the government, keeping the pressure up, and keep amplifying each other's voices and experiences. It's also really important, I think, that we keep supporting our NHS staff, that we support the strikers, and equally you can get involved with existing campaigns. There are loads and loads out there. There are loads that I highlight in the book, or start your own if you want to campaign on an issue where there isn't a campaign that already exists. In terms of your own health, there are various kind of general tips that I give about advocating for yourself. They won't necessarily all work with all healthcare professionals or for all patients, but taking someone with you as an advocate or even really just as a witness can be helpful. Tracking your symptoms, presenting your experience as clearly as possible. So what's happening, how long it's been going on for, what impact it is having on your life. What you want to get out of the appointment, I think actually is something that people often don't realise is really useful to tell your GP, this is what I would like to come away with, whether it is a particular prescription, or whether it's a plan, whether it's a next step forward. Equally, asking your doctor if you're not sure why they're, that you're not sure about their diagnosis or you're not sure about the treatment they're proposing, ask them to justify it. Ask them, why do you think it is this? Why do you think it's not that? Are there alternatives to this treatment option? You're entitled to ask for a second opinion or, even to make a complaint if the care that you receive isn't up to scratch. Doing a bit of research, looking to relevant charities, NICE guidelines, speaking to other patients with similar symptoms, they're all things that can be really useful in terms of going in feeling equipped, that you kind of already have a bit of an idea of what you want to talk about. And social media communities can be a really great resource for this. But in exactly the same way as navigating the wellness industry, you do need to be a bit savvy and have a good level of health literacy to filter through what is useful, what is evidence-based, and what's not. There are also some brilliant doctors on social media sharing information that is trustworthy, that is reliable, that is based on evidence about women's health issues. So they are really fantastic resources who are worth looking to, if you feel that your own doctor is not accessible. Ultimately, though, I think a big thing is around trusting your gut when you know that something isn't right. And remembering that you are the expert in your own body. The expertise that you have in your own body is complementary to the textbook expertise that your doctor has. It's so ingrained in us that the doctor knows best, but actually I think particularly when it comes to women's bodies, that isn't necessarily always true. You and your doctor may be learning at the same time as you go along with some of these issues. The final thing I think we need is a more collaborative relationship between patients and healthcare professionals, which includes supporting those who are striking for better pay and working conditions in the NHS. So in that spirit, I'm going to close the same way I closed the book. First, I'm going to have a drink. So just to put this extract into context, I'm talking here about some of the holes in the government's women's health strategy. These issues will have to be addressed going forwards, but it is welcome news that many of the right conversations are at least being had, even if progress feels frustratingly slow. Much of the political rhetoric is broadly promising, but it will be meaningless unless it's backed up by the government putting its money where its mouth is on funding for research and services. Either way, these conversations show no sign of slowing down, shutting up, or going away. My hope is that they will become more and more collaborative, dialogues between patients and healthcare professionals based on mutual empathy and trust, not dismissiveness or resentment. This will, by necessity, involve hearing and acknowledging some uncomfortable truths. Doctors will have to accept that the way they've always done things may have been wrong or harmful. They'll have to get better at admitting when they don't have all the answers and facing up to what that means for their practice. Many will have to reflect on biases that influence the way they treat their patients and reassess the stereotypes they rely on to make clinical judgments and decisions each day. As patients, too, we need to recognise, but not accept, the limitations of the current broken system and continue demanding the powers that be do something about it. We need to learn how best to work within the system alongside the professionals who care for us, and when and how advocating for ourselves might be useful. Above all, we need to continue speaking out whenever and wherever possible, complaining, expecting better, pushing for research and policy change, and the kind of care we all ultimately deserve. Our rebellious, unruly bodies have been ignored and neglected for long enough. Misunderstood and stigmatized because they're too female, too dark, too broken, too fat, too old, too young, too trans, or too queer. Dismissed as hormonal and irrational, written off as hysterical, as mad, as liars, but rest assured that the fight back is on, and every rebel body has a part to play. Thank you.
Thank you, Sarah. That was a really fascinating account. Thank you. So we'd like to open it up to some questions now, if anybody in the audience has got questions. Yes, we've got a mic, so somebody will come round to you just towards the top first.
Thank you.
Oh, that is loud enough. So I was wondering, to what extent do you think some of these medical issues, whether they can be tackled within kind of like medicine itself, or if it's a wider societal issue that needs to be tackled? So just for like context, one of my work colleagues, he has got whatever the male equivalent of like having your tubes tied is. I can't remember what the word is. But he got that done, easy peasy. He was telling us like how like he just basically went to the doctor and they were like, yeah, sure. Whereas on the other hand, I have a friend whose mother, after having her first child, didn't want any more children, went to the doctor, said, I, want my tubes tied, and the doctor was like, we'll need to get your husband's like approval on this. And it's like, it obviously is a medical issue, but like, to what extent does this go beyond like the doctor's practice and it's into a wider societal issue? If that makes.
Yeah, I think so. I think it is very much a bit of both, and I think the knowledge gap and the trust gap are so kind of intimately intertwined that and the example you give is a really classic one. That men are independent, autonomous beings who can do what they like with their fertility, whereas women, and I hear it a lot, particularly from younger women, being told, oh, you're too young, you might change your mind. All of these really sort of patronising attitudes. I think some of it does come down to, trust policy. It comes down to the attitudes of individual doctors. I think it is something that needs to probably be dealt with at both levels. So whether that's kind of commissioners sitting down and going, right, what is actually our policy on male and female sterilisation? Are we going to fund both equally? Are we going to make it just as easy for a woman to have her tubes tied as for a man to have a vasectomy? But equally, I think if you've got doctors whose attitudes are, we need to check with your husband, then that's a problem as well, and we need to be tackling that misogyny at an individual level as well as an institutional one.
I think it's also about hearing the voices of women. So through the research that I do, it's finding out about those experiences and then portraying them to policymakers, so then at a national level we can make changes.
Absolutely.
Thanks, Sarah. I was going to ask, what's your approach in the book for reaching out to people who believe they are normative, whatever that even means, and also think they are being well served by the way the medical system is currently set up? Because I guess, there's one thing about people who might read the title of the book and go, right, I already obviously don't feel served, and therefore I should read this to get. But I wondered, obviously this needs to be everyone needs to look into it, but I'm a researcher as well in health, and I'm curious about people who already, and from a journalistic sort of perspective, and how you interact with people who think they are being well served by the system. And from a researcher perspective, there's so many things you can think about how actually the attitude that we have is underserving everybody. But I wondered, at community level, dealing with people as journalists, how would you reach out to people who think they're being well served at the moment? Thanks.
Sorry, you mean?
Like the way, so if you say it's this white man or whatever, they think the way everything's being set up right now is actually serving them well, which, when you look at it from a research perspective, it's actually no, because not looking at holistically is underserving everyone.
Yeah, no, absolutely. I think one of the things that I talk about in the book is that many of the changes that would help women, would help people of colour, etc., would fundamentally help make the system better for everyone, because it's things like more individualized care, it's more collaborative approach to GP patient consultations. So certainly that's how I think you would frame it from that perspective. And I think that in terms of the sort of the outreach, the who needs to read this book, I very much have framed this in conversations that I've had as, if you know anybody who is affected by these issues, if you have a mother or a daughter or a sister or an auntie, or even if you yourself have been through this experience, you need to read this book and understand it. So I think, there is nobody that this book isn't for in that sense. And I think it is just about understanding that it's not one of those situations where if you make things better for women or you make things better for disabled people, suddenly it gets worse for everyone else. Actually making it better for marginalised groups makes it better for the whole.
Lots of nods in the audience. Yes. Somebody down here in a stripy top, thanks.
Hiya, thank you for that. So I found it quite interesting you were saying about the women-led products that are really making a difference in healthcare. And what really struck me about that is nearly 80% of NHS staff are actually women, aren't they? So I was wondering, that feels like an opportunity where NHS organisations could be doing more to take advantage of that. So would you say there's something NHS organisations could be doing to utilise the fact that the majority of NHS staff are women in that way?
Yeah, definitely. I think so. I mean, one of the interesting things about the statistics on NHS staff, and I talk about this in the final chapter of the book, which is much more focused on the NHS and on NHS staff and their experiences, is that, women being the majority doesn't necessarily mean that the NHS, that we have equality, okay? So diversity doesn't necessarily equate to equality. And when you look at the structure, the women are in the lower positions and the men are in the higher ones. And similarly with race and other factors, you have a lot more white men at the top than at the bottom. But yeah, I mean, I think absolutely the NHS should be looking to its female staff for that kind of innovation. I think we need to see much, much more diversity at that top level so that the people who are making commissioning decisions, the people who are deciding trust policy, are thinking about these things, because I think often that is, and Hannah, who sat in the front row, who I interviewed for the book, actually said this as part of our interview. Often it is not that people are being deliberately neglectful, it's just that they literally haven't thought of something because it's so far outside of their experience. So if your management is all white men who have never even considered what it's like to have a really horrifically painful period or to be a black woman being denied pain relief in childbirth, then it's just not on the agenda. We need everyone to kind of have a seat at the table.
There's a gentleman here, thank you.
Thank you so much, Sarah, for a really engaging talk. Really enjoyed it. I just wanted to ask about, you spoke about lots of different types of women from different backgrounds and with different perspectives who've experienced things.
Sorry, could you just hold the microphone?
Oh, yeah, sorry. So just based on different perspectives and backgrounds, different types of inequalities and inequities in the health system have been experienced based on race or weight or whether someone identifies as trans. I just wanted to ask about how, whilst representing their specific experiences and backgrounds and struggles, how these different voices can continue to sort of come together and find common ground and sort of provide like a unified resistance movement. So it's just they're sort of really appealing to the specific struggles they go through, but also pushing for something which is unified and collective.
Yeah, no, absolutely. I mean, I think one of the things that I really wanted to do with the book was to highlight the commonalities, the fact that, particularly when it comes to trans health issues, I think there is often so much kind of divisiveness. I wanted to really highlight the things we have in common. And not all of our struggles are the same. Some of our struggles are very different. but ultimately we are fighting the same fight, and having an understanding of different people's different experiences is useful, I think, for everyone to be as part of that. You know, we need this whole struggle to be inclusive and for everyone to be involved. You know, it doesn't really help everyone if it's only white, middle-class, cis women who are seeing benefits from this. So, yeah, that was what I really wanted to do was to just show that you know, we're all fighting the same thing, and we need to do it together.
Thank you. I think there was a question down here.
Firstly, thank you for validating a lot of I'm sure struggles that people have gone through and adding to this discourse. I just wondered, under the prong of knowledge, to what extent do you think the reason women have been marginalised in healthcare for so long is misogyny, and to what extent do you think it is the fact that women throughout our lives aren't there's so many transitions from menarche through to menopause beyond, do you think in science men have been seen as the norm because they're easier to study and have less of or kind of
they're less complicated.
Hormonal fluctuations, and I just wondered to what extent you covered that in the book.
Yeah, absolutely. I think it's a really good point, and you know, as I said before, I think it's a little bit of everything, but I definitely think that's a factor. We know that part of the reason that women have historically been excluded from research and from clinical trials, for example, is because having to factor in menstrual cycles makes your research more complicated. You know, you have to factor in where somebody was in their cycle when you did a particular particular test or whatever it is. And that's more complicated, it's potentially more expensive, and so researchers have just gone, oh no, I can't be bothered. They're basically, women are the same as men but with boobs. It'll work. So yeah, it's been a huge part of it, I think, and one of the real tragedies is that as a result, you know, there are so many, I explore this particularly in the chapter around disability, there are so many of the chronic illnesses that I mentioned earlier, where researchers are now saying, we think the reason it mostly affects women is something to do with hormones. But nobody's ever researched those hormones because they were too complicated and too expensive. So we actually have no idea. We can't prove it. We don't know what the mechanism is. And there are so many of these fascinating kind of medical mysteries that I think could be unlocked if researchers just kind of embraced the menstrual cycle and got stuck in. And I think that is starting to shift. But I think, you know, there's a huge amount of catching up to be done there.
I think it's also, you say in your book, because kind of medical textbooks were developed at a time when medics were men, basically. The images in the books, a lot of the anatomy in the books are male bodies. And so I think it was until about the 50s there were quotas in medical school that stopped women from studying medicine. So we're only now seeing there's more female medical trainees now than men, but that's only in the last 10, 15 years. So hopefully as more women come into medicine and in senior roles, like you say,
absolutely.
Hopefully it will improve. Yes, thank you.
Hello. Oh, you can hear me. I just wondered in your book how you manage or navigate around the health inequalities of the life expectancy of men being always below women in, I think, every country on the planet, which is usually quite a significant indicator of health inequalities. I just wondered, do you refer to that? Do you, how do you navigate around that?
Yeah, so
the big inequality.
I do refer to it, and I talk about the fact that, as you say, women do tend to have longer life expectancies than men. The kind of interesting statistic that I put alongside that is that actually women spend much more of their lives than men in ill health, so affected by disability, affected by chronic illnesses, chronic diseases. So it's and there are lots of kind of complicated reasons why those disparities exist, and that's slightly beyond my scope of expertise, but certainly it is addressed in the book. And I think, you know, the fact that, you know, men are living shorter lives, but they're well for the whole of their lives is what I think comes across.
So I think we've just got time for one more question. There's a lady here in a white t-shirt, just around.
Thank you very much for your talk and for writing this book. And I was just wondering if you could tell us a bit more about your process of the interviews, because it sounds like it could be potentially painful or really frustrating kind of topics that you might have covered. Yeah, I was just wondering if you could tell us a bit more of how you sort of navigated the interview process.
Thank you. Yeah, that's a really interesting question. I mean, I think my approach always as a journalist is I write about lots of very sensitive topics. So even long before writing this book, I've kind of had to navigate that. And my approach is always, you know, I make it very clear at the start of any interview, this is what I would like to talk about, but I will be led by you. And if there's anything we don't want to talk about, if you need to stop, if you need to take 5 minutes, if you need to just go away and we can finish this another day or later on. So I'm always very kind of open to what the interviewee needs, because I think that's important, you know, because they are giving me something of themselves that is really deeply personal, and they're trusting me with that story. You know, equally, I sent quotes to every single interviewee to check that they were happy with them before the book was published. But I think, you know, what I have been really kind of moved by actually is the feedback from a lot of the people I interviewed has been much more, not that it was traumatic for them, but that actually it was cathartic for them to be able to share that and to be able to share it with somebody who listened and who heard and who believed them and who took their experiences seriously, and to be able to have that story published and you know, see it there alongside lots of other stories and to go, oh God, yeah, there are loads of us. I'm not on my own, and you know, all these other people have kind of got my back, was a really positive experience, I think, for a lot of the people that I interviewed, hopefully all of them.
Thank you. So I'd like to thank Sarah again for her talk today. It's been really fascinating, and thank you as well for your questions. If you'd like to, after the talk today, there'll be sales of the book outside, and Sarah will be signing copies as well if you'd like to get one of those. So if we just have a round of applause and thank Sarah.